This is Chapter 11, Patellofemoral Pathologies. The patella is a sesamoid bone that sits at the distal end of the femur. Anteriorly, we use the edges of the patella in the four cardinal directions in K position: superior, inferior, medial, and lateral. It is divided into three facets on the posterior side: lateral, medial, and the odd. The odd is the most medial facet. The medial and lateral facets can then be divided into superior, middle, and inferior articulating surfaces, making the posterior surface of the patella a 2x3 grid. The odd facet does not really have enough articulation to divide. The patella becomes a solid bone between 3 and 6 years old. In uncommon cases, it does not fully ossify, leaving a weakness in the bone. This is called a bipartite patella. Because the integrity of the bone is weaker, the usefulness of the pulley it creates is decreased. Knee extension strength suffers because of this, and half of the cases of bipartite patella are bilateral. The patella acts a little differently from weight-bearing to non-weight bearing. In non-weight bearing, it moves over the femur. In weight bearing, the femur moves under the patella. Something to think about clinically. Knowing this, what muscles tend to control the motions of the femur? Thus, what muscles will we look for deficiencies when presented with the patellofemoral problem? Think about this for the next class. We will come back to this point. And also, what does the chart on the right say about the range of motion degrees with the largest contact area? What is significant about that angle of knee flexion? There are multiple things to think about with that one. Again, we will come back to it during the next class. And when we talk about the patella, we also need to understand the joint reaction forces placed upon it. There are forces pulling superior, the quadriceps tendon, and inferior, the patellar tendon. There are also forces pulling anterior and posteriorly when moving through the flexion, extension, and range of motion. As it says on the slide, you can get up to 7 times your body weight worth of joint reaction forces placed on the patella. Using the information from the last slide, what range of motion degree has the peak forces? How does that manifest clinically? Plus, as the knee moves from an extended position into a flexed position, those joint reaction forces increase significantly. The little league catcher who goes into the deepest squat possible to sit on his knee savers probably harms his knees more because of that. The next portion of the anatomy are the patellar retinaculum and patellofemoral ligaments. The two retinaculum, medial and lateral, keep the patella on their respective sides. The lateral retinaculum pulls lateral to prevent medial subluxation, and the medial retinaculum does the opposite. The medial tends to be thinner than the lateral. And you see that the retinaculum are fibers from different muscles on their respective sides. This is another reason to look at muscle function when evaluating patellofemoral issues. Because the medial retinaculum is thinner, the medial patellofemoral ligament is the primary restraint against lateral displacement. One thing to note is that some fibers of the MPFL are often shared with the MCL of the knee. So, a significant MCL sprain could have an influence structurally on the patellar restraints. Biomechanically, it could make a difference as well. This slide will discuss the muscles in the bursa around the patella. Primarily, you have 3 superficial quadricep muscles. The vastus intermedius has the same line of pull as the rectus femoris. You will see on page 383 in the book that the vastus lateralis and vastus medialis pull the patella approximately 45 degrees off-center in their respective directions. Having those two muscles balanced is important. What is an injury state where that may not be the case? Typically, in this situation, we hear about the vastus medialis obliquus, which pulls the patella at about a 55-degree angle medially due to a different fiber orientation. This is another restraint for lateral subluxation. Moving back up the bullets, I mentioned the patellar tendon length. Normally, the distance between the superior and inferior poles of the patella should be very close to the distance between the inferior pole and the tibial tuberosity. We will talk about what discrepancies in those measurements translates to in another slide. The right side of the slide lists the various bursa around the patella. Remember that bursa are thin layers of tissue that are protecting areas and lubricating muscle bone junctions to facilitate easier motion. The infrapatellar fat pad is also mentioned. It is unique because it is an intracapsular but extrasynovial structure. It separates the patellar tendon and deep infrapatellar bursa from the joint capsule. It It can be palpated, especially when inflamed, immediately to the medial and lateral side of the patellar tendon when in full knee extension. That is the lecture for now. Please make sure to note my questions posed in this lecture because you will hear them again.